So I will give you now an overview how our understanding of ME/CFS was also accelerated by long COVID research. Next slide, please. And one further. Can I do this by myself too? Yeah, so I'm going to talk about what have we learned and where have we made progress. And I will briefly give an overview that ME/CFS is part of the spectrum of long COVID, and then come to the key pathological findings. And here you see my disclosures. So ME/CFS has been a disease of neglect, misdiagnosis and underfunding for decades. Well known as the Royal Free epidemic almost 80 years ago, in which ME/CFS was misclassified as an epidemic history and was due to the high attack rate in females. That was the rationale at that time. And then the PACE trial is also a part of a dark chapter of ME/CFS research and misunderstanding. And the concept which led to this trial was that it's a disorder of perception and a dysfunctional illness belief. And this concept and these trials did a lot of severe harm to our patients. Unfortunately, ME/CFS still is a disease of neglect, misdiagnosis and underfunding, which is well illustrated, for example, in this documentary film Chronically Ignored. The good thing is that the emergence of long COVID has also brought several positive developments for ME/CFS. So we have the scientific acceleration with establishment of new research groups and consortia. Of course, there are many of the people working in these consortia here today. We have a growth in biomedical studies. We have initiation of therapeutical trials. There weren't hardly any therapeutical trials in ME/CFS until 2022. And we have raised public awareness. ME/CFS is all in the mainstream media since 2020. We also have some journalists here today. I'm very grateful to you that you have raised awareness during the last years. We have a policy shift, so we have research funding which strongly increased in several places during the Biden government period, and also during our last government period when Karl Lauterbach made possible that we got funding of 150 million euros for care structures in ME/CFS and long COVID, and I'm very happy that he will speak here tomorrow. And of course we have the patient-led science and advocacy networks, as you just heard, for example, from Hannah Davis in Germany, or from Long COVID Germany and all the other patient groups. So long COVID is actually not a new disease, but we have known this disease for long, that viral infections, but all the other infections can trigger post-acute infectious syndromes, as we call them, with many similarities. And we know that ME/CFS is part of it and is the most severe form of such a post-acute infection syndrome. Long COVID comes with many different symptoms. That's probably a special feature of this virus, because it so broadly infects the body. But we learned also that the key symptoms of ME/CFS, fatigue and post-exertional malaise, are also the most frequent symptoms of long COVID. And I show here a figure from the Recover Consortium in the US. I think, David, you participated in this study too, showing that the fatigue and post-exertional malaise was key symptoms in almost 90% of the long COVID patients too. At Charité, we initiated a study already in summer 2020 also to learn more about long COVID, and with a specific question if ME/CFS is also triggered by SARS-CoV-2. And I briefly want to summarize our findings. So what we learned is that ME/CFS is triggered by COVID, yes. Not all patients who came to our clinic with fatigue and post-exertion malaise did fulfill the Canadian diagnostic criteria for ME/CFS, but probably half of these patients did. And we know now that approximately 10 to 20% of all long COVID patients do fulfill these Canadian criteria for ME/CFS. What we also learned is that ME/CFS triggered by COVID looks very similar to ME/CFS triggered by other infections, and that is shown here. Though these were the patients seen at the same time who had ME/CFS triggered by another infection. These were the patients triggered by SARS-CoV-2. The Bell Disability Scale is in both groups very similar, so these patients suffer from severe functional impairment. This is the group not fulfilling the Canadian criteria, and they were not that sick. We also see that severity of fatigue assessed by the GELDA fatigue questionnaire is similar in the ME/CFS groups, not so much in the post-COVID people, I call them here. And also the severity of post-exertional malaise is very similar. Then we also followed our cohort for almost 2 years, and that is shown here on the right side. And we assessed here the SF-36 physical function, which is a good questionnaire to quantify the daily limitations the patients do have. And patients are usually quite sick, so 0 means bedridden and 100 means healthy. Every blue dot is an ME/CFS patient, and you see that this disease becomes chronic with little improvement over this 2 years, and we have now patients who have been sick for 4 years from COVID, and we see no really improvement with the treatments we have so far with symptomatic therapy. We can, of course, alleviate symptoms, but we cannot really influence the disease course. This is just a brief overview about the clinical phenotype of ME/CFS and the key facts. And so besides PEM and fatigue, patients do suffer from brain fog, from severe concentration problem. Many patients have headache, have muscle pain, sleep disturbance is very typical, orthostatic intolerance. So it's a very severe disease with a high disease burden, and as I said, it looks very similar, either triggered by SARS-CoV-2 or by other viral infections. We have known already that it was a frequent disease pre-pandemic. This is a very conservative estimate based on epidemiological studies of 0.1.5 to 0.3% pre-pandemic, and we are quite sure that the numbers have doubled to 0.6%. There are numbers which are even higher. It has been classified as a neurological disease in ICD for almost 100 years. 50% of the patients are unable to work, and the rest is usually only able to work part-time. 25% are severely ill, and a subset of these patients are bedridden. And the true fact is we have no specific treatment so far, and no adequate care structures for ME/CFS, and that is true worldwide. This is a review article written by my colleague Franziska Sotzny from 2018, where we tried to summarize what was known about the pathomechanism at that time. And we had already good evidence that it disease of the immune system, that by infection, immune dysregulation is triggered with inflammation, autoantibodies, that we do have severe autonomic dysfunction in many patients, and also metabolic dysfunction. At that time, we didn't really know well how this is all interconnected. And the good thing is that we have, during the last years, learned much more, and we actually weren't that wrong already in 2018, so we still think that these are the key pathomechanisms. And in long COVID, very similar pathomechanisms were found. Here you see, again, we have clear evidence for inflammation, for autoimmunity, autoantibodies. We do have evidence for disturbance of the autonomic nervous system. We do have evidence for metabolic dysfunction with a disturbed mitochondrial function in the center of the disease. Probably virus persistence is not the key problem in ME/CFS, at least. There was this large US study published by Swank as first author, showing that spike is found in some healthy people too, and of course in patients, but not more frequent in ME/CFS patients. And that is also what we found in our Charité study on analyzing spike protein in the serum. So this question is still open about the role of spike and SARS-CoV-2 persistence in ME/CFS. What is known for sure, and I think this is again very interesting data also for ME/CFS, is that herpes virus reactivation plays a role, and that EBV reactivation during acute COVID is a risk factor for long COVID. And EBV is known as the most important trigger for ME/CFS too. So coming to the findings about autoimmunity and autoantibodies in long COVID, we again had several similarities to what we've known already in ME/CFS. So there's not the only specific antibody found in long COVID, but in most for the antibodies, we only have smaller groups of patients. What we found is that neuronal antibodies are quite frequent, as David just showed. Muscle antibodies, ANAs, are elevated in about 20 to 30% of long COVID patients. And those which I circled red are the antibodies which we've known already to be found in ME/CFS patients. And among these antibodies, the most interesting are those against the so-called G protein-coupled receptors. And we've learned during the pandemic and the long COVID studies that they seem to play also a role in long COVID. And the intriguing finding from these studies also that many showed that the higher these antibodies are, or if they are present, then this is associated with severity of key symptoms. So the G protein-coupled receptor antibodies are actually a specific sort of antibodies. They are regulatory antibodies, and they are natural antibodies, meaning that they do actually play a role also in healthy people, helping us probably to coordinate the function of G protein-coupled receptors. And thanks to the pioneering work also of Harry Heidecke and Kai Schulze-Förster, who founded the company Celltrend, we have the possibility, or we had the possibility quite early to analyze these antibodies in ME/CFS and also in long COVID. There are antibodies against several receptors which seem to play a role in this disease, adrenergic receptors, acetylcholine receptors, angiotensin receptors, among others. We have learned during the last days, and that is also work mainly from Gabriela Riemekasten, who is here today too, that the levels and the function of these antibodies are altered in many autoimmune diseases. and that the levels correlate with symptom severity and disease manifestations in various autoimmune diseases and beyond. Also neurodegenerative diseases, we have data now in cardiovascular diseases and also in ME, CFS and long COVID. And then we do also have evidence that Epstein-Barr virus plays a role in triggering autoantibody. Epstein-Barr virus actually plays a role in many autoimmune diseases well known in multiple sclerosis. And in multiple sclerosis, one of the antibodies which has been well known is against myelin basic protein. And we know that there's a mimicry that antibodies which were triggered against EBV recognize this protein as a neural protein because this has a high sequence similarity. And this is a study I show you by the group of Ron Davis. And what they found is that about half of the patients with ME/CFS do have antibodies against the myelin basic protein 2. We will hear more about antibodies triggered by EBV also in the session thereafter. As I said, we see these associations of antibody with clinical symptoms, but this is still no proof that they are disease relevant. What is already a very strong evidence are these IgG transfer animal models. David Putrino already showed data, and Jérôme van Den is here today and will later in the afternoon also show his studies sharing similar finding. And then finally, of course, if we really want to know if these antibodies are disease causing, we have to treat patients with autoantibody targeting therapies. And this is ongoing, and we will hear more about this also tomorrow. So before I come to an end, I just want to mention another group of studies I consider very important and similar to our understanding of autoimmunity. We have also learned from long COVID studies more about the role of metabolic dysfunction, and this most intriguing finding comes from skeletal muscles studies, and we will hear also this afternoon some of the key findings. You also see some of these findings on posters outside. What we know for sure, you see this also in a poster from Ruud Vermeulen, that the muscle force is severely impaired. You can assess this by hand grip strength. It's impaired already quite early in the disease, we learned, and it correlates with severity of key symptoms and prognosis. So this seems to be in the center of the disease. We have this exercise testing study. One of the pioneers is David Systrom. We'll also present this afternoon. We've learned that we have this early appearance of this anaerobic metabolism. We have diminished oxygen uptake and extraction, and we performed an MRI study showing that sodium accumulates in the muscles, which tell us that the homeostasis of ions in the muscle is severely impaired, which may result in muscle and mitochondrial damage. And Klaus Wirth will talk about this later on. And then these most important biopsy studies showing muscular damage upon exertion, which were performed by Rob Wüst. He's going to present this data this afternoon. And several studies provided evidence for mitochondrial damage, for mitochondrial dysfunction and even damage. That was shown by Jürgen Steinacker and will also be presented this afternoon. And a very recent study from Rob Wüst also showing that capillaries are rarer and are thickened in the muscles of ME/CFS patients. So to sum up all these findings, we know that ME/CFS is a severe and chronic form of post-COVID syndrome, and we have clear evidence now for a role of autoantibodies in ME/CFS and in at least a subset of post-COVID patients, probably also not in all ME/CFS patients, though it looks as if we also do have only an autoimmune subset, and we will learn from Birgit Sawicki's studies on B-cell subsets more this afternoon. We know that there's ongoing low-level inflammation. Anna Aschenbrenner will show us single-cell RNA data this afternoon. David showed already we have the severe problem of vascular dysfunction, of hypoperfusion, and of muscle mitochondriopathy and damage. So we have this finding, but we still have to face these major challenges, that we do have these inadequate care structures, we have the lack of effective treatment, and therefore I think this is a very important study. That's the economic study which was issued today by the ME-CFS Research Foundation, and it shows that the costs of ME-CFS and long COVID are very high for society. So it sums up the costs for ME-CFS patients pre-pandemic and triggered during the pandemic, and also for long COVID patients, to a total of, now I say it in English and German, in German it's 60 Milliarden Euro. In English it's 60 billion. Billion is in German more, but so it's a number which is in no relation to what has been put into funding at the moment. Therefore, we really want to raise awareness again that the most expensive thing we can do is not funding research and not developing trials, not developing drugs and trials. And so the return of investment, as an economic person would say, is really high in ME-CFS. So, and therefore we are issuing today also an international declaration in support of research and drug development for ME-CFS and long COVID, to be signed hopefully by most of the leading physician scientists and public health professionals worldwide. It was sent already to those speakers and chairs of this meeting, and you can either send back an email or you can sign it here also, where you this morning got your name badge, and you can also sign this later on. So no, this I didn't want to show. Okay, so now that was all I wanted to say. We have a few minutes time if there's one burning question. If not, I would give a brief introduction to the next session.